Hello, guys. So, today we will be talking about your electrolytes. So, we are already on the second half of the term. So, like I said, karon pa lang, do improve your spelling and also your essay skills because you will be talking a lot about certain processes. Medyo, medyo ano siya, medyo heavy ang from this point forward because there will be a lot of compensatory mechanisms. It will get a bit confusing as well. So, I hope makakeep up ang tanan and as much as possible, do try to uh, take notes, I guess, on some of the things that you find a bit lisod so that you can review more on it. So all of the things that I've placed here sa PowerPoint can be found sa Bishop Gihapon. Okay. So objectives for this discussion is to understand what electrolytes are and their role in the body, their significance, and to be able to provide a brief introduction to common electrolyte disorders, to explain sodium's key functions, including maintaining fluid balance, nerve transmission, and muscle function, to understand the relationship between sodium intake and conditions such as hypertension and cardiovascular disease. Okay, electrolytes are your ions or minerals capable of carrying an electric charge. We have two classifications of your electrolytes based on charge. So we have anions. Those are the electrolytes that have negative charge, such as your chloride, your bicarb, okay, and they move towards the anode. You have your cations, your positive charge and moves toward the cathode. The example of your cations are your sodium, potassium, magnesium. Those that have a positive charge. So for the functions of your electrolytes, it is for volume and osmotic regulation, myocardial rhythm and contractility, cofactors in enzyme activation, regulation in adenosine triphosphate ion pumps, acid-base balance, blood coagulation, neuromuscular excitability, and the production and use of your ATP from glucose. Okay, so water is or comprises 40 to 70% of our total body weight. So women have less water content than men, and it's probably because of the high fat um, content in women rather than men. Okay, so water is considered to be the solvent for all processes in the human body. It is responsible for the transport of nutrients to cells, responsible also for cell volume by its transport into and out of cells, and it is responsible as well for the removal of waste products by way of urine and acting as the body's coolant by way of sweating. Okay, so water is divided into two types sa atong body. We have the intracellular fluid. Those are the fluid which is inside the cells and comprises two-thirds of the total body water. And we also have the extracellular fluid, which accounts for the other one-third of the total body water. It is subdivided into three: the intravascular, interstitial, and transcellular. Okay, so intravascular, these are your plasma. And cases na normal plasma, usually there's 93% water. Okay, the remaining volume would be the lipids and lipoproteins. The interstitial fluid are the fluid that surrounds the cells in the tissue. Okay, katong just outside lang sa cells na fluid. And then we have your transcellular fluid, those that are naa sa mga linings sa tong epithelial cells. Those such as your cerebrospinal fluid, those fluids sa joints, mga ano. Those are your transcellular fluid. Okay, so active transport is a mechanism that requires energy to move ions across cellular membrane. So we have two types of transport. We have the active and the passive. So like we said, active requires energy, whereas your passive does not require energy. So the passive movement na siya. Passive movement of ions across a membrane and depends on both the size and charge of the ion being transported and on the nature of the membrane through which it is passing. So the distribution of water, so this is controlled by maintaining the concentration of electrolytes and proteins in individual compartments. Most biologic membranes are freely permeable to water, but they are not permeable to ions and or proteins. So the concentration of the ions and the proteins on either side sa membrane will influence the flow of water across a membrane. So this is called your osmoregulator. Your sodium, other ions, proteins, and blood pressure also influence the flow of water across a membrane. So ang ato ang membrane kasagaran is easily permeable to water, but selective siya sa kanang ions and proteins and your sodium and ano. So usually it requires active transport na siya. Osmolality is the physical property of a solution that is based on the concentration of solutes per kilogram of solvent. You can think of osmolality as how concentrated the blood is or the amount of solutes are in the blood. Kumbaga, kung ang blood is mostly water, so baba ang osmolality niya, it is usually it you can consider it na diluted kaayo. If concentrated kaayo siya, then taas ang osmolality niya. Okay, so it is based on the concentration sa solutes. Whenever we're testing for the electrolytes, we have to base it on the colligative properties such as the freezing point depression and the vapor pressure decrease. So most of our ions are being tested using freezing point depression. The increase in our osmolality of the blood stimulates two things. It stimulates thirst and it also stimulates the AVP release. So the sensation of thirst, this is the natural response. So ang natural response niya is mag-consume ta og more fluids. So if we consume more fluids, naga-increase ang water content sa extracellular fluid and this dilutes the elevated na solute to decrease the osmolality of the plasma. So that is the compensatory mechanism sa ato ang lawas. Pag medyo concentrated na ato ang blood with all the solutes that we have the salts, the glucose, and the sodium and everything. Tapos medyo concentrated na siya, so the body's response ana is the sensation of thirst in order to somehow dilute the elevated solutes and decrease the osmolality of the plasma. So we also have the AVP release. So your AVP acts on the collecting ducts in the kidneys to increase water reabsorption. So water is conserved and the osmolality will decrease and it shuts off AVP secretion. So this is an example of your negative feedback loop. So pag taas kaayo ang concentration sa solute sa blood, send siya signal sa ato ang hypothalamus to release vasopressin. Okay? And then, after it's being released, increase ang water reabsorption, naga-dilute na ang ato ang concentrated blood, na dilute siya sa water. And then, since dili na siya kayo concentrated, nagababa na ang osmolality. So, kung nagababa na ang osmolality, it will send a signal sa ato ang brain na pod na enough na ang need for reabsorption of water. So it shuts off the AVP secretion. Your AVP or your arginine vasopressin acts by increasing the reabsorption of water in the cortical and medullary collecting tubules, but has a half-life of only 15 to 20 minutes in the circulation. The clinical significance sa ato ang osmolality. So we have, the osmolality is the parameter to which the hypothalamus responds. Kung taas ang osmolality, mag-release siya AVP. Kung baba ang osmolality, it shuts off the release of the AVP. So, naga-base ang ato ang hypothalamus sa osmolality sa ato ang plasma. So, its regulation, the regulation of our osmolality, primarily affects ang sodium concentration nato. The normal reference range for our serum osmolality is 275 to 295 milliosmoles per kilogram. 1% to 2% increase in osmolality can already trigger 4 times the increase in AVP. However, 1% to 2% decrease in osmolality will shut off the AVP production. So, our brain or certain receptors sa ato ang lawas are in charge of sending signals to the brain pag manotice niya na nagasaka na ang osmolality or nagababa na ang osmolality sa ato ang lawas. The regulation of your blood volume depends on the osmolality and the volume, and your osmolality is regulated by the changes in water balance, and the volume is regulated by the changes in sodium balance. Okay, di ba pag baba ang blood pressure, kasagaran, baba po ang blood volume, and then that's where your RAAS comes into place. For your renal water, excuse me, renal water regulation. So, renal, meaning ato ang kidneys, how it regulates the water. So, pag naay water excess water sa ato ang body, it is controlled by the renal water excretion by way of urine or urination. Pag water deficit, such as in the case of dehydration, so it is prevented by the sensation of thirst, which will tell us or tell our body that we need to drink more water. So one scenario here is the water load. Okay, as in the case of our kato ang diabetes insipidus or diabetes, if we are experiencing polydipsia or in excessive thirst. So kung sige-sige tag feel o kanang uhaw kaayo ta, so it will cause an excess intake of our water. And then, pagtaas kayo ang intake sa water, di ba, we said earlier, na it will dilute the sodium concentration sa ato ang body or the ion concentration sa body. And then, mababa ang plasma osmolality nato because diluted na ang fluids. So, kung baba ang osmolality, we don't need AVP release anymore, di ba? 1% to 2% decrease in your osmolality will stop the production of your AVP. So, kung baba na po the osmolality nato, so, dili na po siya mag-send signal sa ato ang brain na uhawon ta because kinasuppress niya ang thirst. So, pag absent ang AVP, since ano nato siya, baba man ang osmolality, so dili man mag-produce ang ato ang body o vasopressin, if it is absent, then dili ma-reabsorb ang water. So, water is not reabsorbed. So, in the case of polydipsia, where it causes the excess intake of H2O, nagababa ang osmolality because of the dilution, AVP is absent, walay gina-reabsorb na water. So asa mo adto ang tanang excess water na gi-intake nato, it will get excreted. Okay? Up to 3 to 20 liters per day. So imagine drinking up to 20 liters of water per day. And then nagasigipod kag ihi-ihian na the whole time because none of those water is being reabsorbed due to the hormone vasopressin being absent. So this can cause hypoosmolality and hyponatremia as well. Baba ang osmolality and baba pod ang sodium due to the diluting effect of your water. In the case na pod of dehydration or water deficit, so naga-increase ang ato ang plasma osmolality because wala kayo ta naga-drink og water. So naga-concentrate ang solutes sa sulod. And then, pag musaka ang osmolality sa ato ang lawas, it will send signal sa brain na dapat mag-activate siya og kato na duha ka regulatory mechanism sa atong lawas, the thirst and the secretion of our vasopressin. So thirst is the major defense against hyperosmolality and hypernatremia. Hypernatremia rarely occurs in a person with normal thirst mechanism and access to water. Since dili man magsaka ang sodium content nato because eventually we will be feeling na uhaw kayo ta because naga-react na ang body na medyo baba na taas na kayo ang osmolality, naga-concentrate na. So it will ask for water. And if kabaluta or we are able to get hold of that water or ask for water, then hypernatremia will not happen or increased sodium will not happen. However, if bata ka or or kanang naa kay disability to convey your need for water, then it becomes a risk factor for your hypernatremia. And then we also have the osmotic stimulation of thirst, which diminishes people who are older than 60. Diabetes insipidus is a disease of water and salt imbalance. So when we have diabetes insipidus, there is a deficiency of AVP, which causes the increase in urinary excretion because wala ginari-absorb ang water. So, because naga-increase ang excretion, it is being combated po by thirst, which is effective in preventing dehydration. Kana lang po, sa sobrang na to kauhaw, when we have diabetes insipidus, sobrang to kauhaw, so nagataas ang water intake na to. So, dili jud ta maka-experience og hypernatremia because gaka-diluted man ang sodium and then magsige-sige man tag-ihi. Okay? So, the regulation of blood volume, okay, or the blood pressure, we have your renin-angiotensin-aldosterone system. This responds primarily to a decreased blood volume, and your renin, your hormone renin, is secreted in response to the decreased renal blood flow. So please do watch
In this
this
video, we will
about the
discuss the
renin
renin-angiotensin-aldosterone system. And before getting into all the complex stuff, let's have an overview of this system. So whenever your blood pressure falls, known as hypotension, the kidneys are able to sense it and they activate the renin-angiotensin-aldosterone system, which acts on kidney as well as the blood vessels to restore the blood pressure to the normal. Most of you know the kidneys are supplied by a set of renal arteries, which supply almost 20 to 25% of whole cardiac output to kidneys. This blood reaches the glomeruli through the afferent arterioles and leaves the glomeruli through the efferent arterioles. These cells you see are the juxtaglomerular cells. The word juxta means near, hence these cells are located near the glomerulus. These cells secrete a substance known as prorenin, and hypotension is a main stimulator of converting prorenin into renin. Renin is an enzyme which acts on angiotensinogen. The word angio means vessels. The word tensinogen means a substance which constricts the vessels. It is a plasma protein which is synthesized in the liver. Renin converts angiotensinogen into angiotensin 1. The next step takes place in the lungs when the enzyme angiotensin converting enzyme acts on angiotensin 1 and converts it into angiotensin 2. The angiotensin 2 is a powerful vasoconstrictor which mediates the effects of renin angiotensin aldosterone system. Let's look at the effects of angiotensin 2 on blood vessels. As I said, angiotensin 2 is a very potent vasoconstrictor. It constricts both the arteries as well as the veins. The constriction of the arteries leads to a total peripheral resistance increase, and the constriction of veins lead to increase in the venous return to the heart. Both these mechanisms increase the blood pressure of the person. This effect is rapid and takes a few minutes. Now let's look at the effects of angiotensin 2 on the kidneys. These effects are slow and take a few days to have their maximum effect. Angiotensin 2 acts on kidney in two ways. The first is the direct mechanism. As most of you know, the GFR of the kidney is directly proportional to the blood flow through the kidneys. The blood enters the glomeruli through the afferent arterioles, and angiotensin 2, being a powerful vasoconstrictor, constricts these afferent arterioles mainly and decreases the blood flow through the kidneys. This results in a decrease in the GFR of the kidney, which results in a decrease in the urine output through the kidney. Now, second is the indirect effect, in which the angiotensin 2 acts on the adrenal gland and releases aldosterone. Aldosterone in turn acts on the kidney and increases the sodium reabsorption as well as the water reabsorption. So we have a decreased urine output, increase in the water reabsorption, and increase in the sodium reabsorption. All these effects lead to an increase in the extracellular fluid of the body, an increase in the capillary pressure, and a long-term increase in the arterial pressure. So to summarize, let's suppose a person gets stabbed and he loses a lot of blood. This will lead to a decrease in the blood pressure of the person known as hypotension, which is a potent trigger of activation of renin angiotensin aldosterone system. The RAAS further acts on the blood vessels as well as the kidneys and normalizes the blood pressure. So this was all about the renin angiotensin aldosterone system. Thank you so much for watching this video. Like our channel on YouTube for all the
Okay, so that is for your renin-angiotensin aldosterone system. So it has two effects. It can either constrict the blood vessels in your afferent na sa kidneys, and then which increases the blood pressure and in turn increases the blood volume, or it has an indirect effect which can cause the release of your aldosterone, which is responsible for your sodium reabsorption. So we already mentioned ang katong ano na to uh, duha ka hormones na to. We have for reabsorption. We have your arginine vasopressin for the reabsorption of water. And then we also have your aldosterone, which is in charge of the reabsorption of sodium. And where sodium is, your water will follow. Okay? So, pag mag-reabsorb ta og sodium, nagasunod pod ang tubig. Okay? That's why pag naga-increase ang sodium reabsorption due to aldosterone, naga-increase po ang water reabsorption. Okay. So changes in blood volume detected by receptors located in your cardiopulmonary circulation, carotid sinus, aortic arch, and then your glomerular arterioles. So the receptors will activate your effectors, which will restore volume by appropriately varying vascular resistance. So naga-produce siya og resistance when the blood vessels become constricted. Okay, kay dili na smooth ang flow kay constricted naman siya. So, nagataas pod ang pressure niya. Okay, cardiac output as well, and then your renal sodium and water retention by means of the aldosterone release. There are four factors affecting your blood volume. We have your atrial natriuretic peptide, volume receptor independent of osmolality, glomerular filtration rate, and the increased plasma sodium. Sa atrial natriuretic peptide or ANP, it promotes sodium excretion in the kidney. So, this is released from your myocardial atria. The volume receptors independent of osmolality will stimulate the vasopressin release, and the glomerular filtration rate will increase with volume expansion and decrease with volume depletion. Increased plasma will also increase urinary sodium excretion and increase water excretion as well. So the reabsorption of the 98 to 99% of filtered sodium conserves nearly all of the 150 liters of glomerular filtrate produced daily. A 1 to 2% reduction in the tubular reabsorption of sodium will increase water loss several liters per day. Okay, so whenever there is a problem sa reabsorption nato of sodium, pila ka liters pod ang malose nato na water daily. Conditions related to urine osmolality, we have your diabetes insipidus and your excessive water intake. Okay? Naga-decrease siya because sa diabetes insipidus, di ba magsigitag intake og water and then wala ato siya wala nag-reabsorb pero okay, baba ang ato ang osmolality. Okay? Then we have excessive water intake, of course, naga-dilute gihapon. So naga-decrease ang urine osmolality sa ato ang ah nag-decrease ang kanang urine osmolality. So we have increased urine osmolality due to the syndrome of inappropriate ADH and hypovolemia. Okay? So these are the um tawag ani conditions in which makita na to ang decreased osmolality sa urine and increased osmolality sa urine. So determination of your osmolality, we could use either the serum or the random urine samples. Random, that is not pasabot na kanang and maski kang kinsa, but maski unsa na time. Okay, random urine sample. So your plasma is not recommended because osmotically active substances may be introduced to the specimen from the anticoagulant. Okay, we use the osmometer which operates using freezing point depression, and it is standardized using the sodium chloride reference solutions. Your osmolar gap is the difference between the measured osmolality and the calculated osmolality, and it indirectly indicates the presence of osmotically active substances other than your sodium, urea, and glucose. So we have your ethanol, mannitol, ethylene glycol, isopropanol lactate, and beta hydroxybutyrate. So you can get these substances either through medication or however form of ingestion or maybe in vitro um, na mga such as your anticoagulants, so mga ingon ana. Ethanol, so we get that through drinking alcohol. Okay, whenever we have to calculate the osmolar gap, we use either of this kanang solution. Before, during our time, we used the 1.86 sodium plus glucose over 18 plus BUN over 2.8 plus 9. But I guess sa karon na time, you can round it off to a whole number and wala na ka nag-a-add og 9. So either of these solutions will work when computing for the osmolar gap. These are the reference ranges for your osmolality. Serum would be 275 to 295, like mentioned earlier. 24-hour urine, reference range is 300 to 900 milliosmoles per kilogram. The urine to serum ratio, okay, it is 1.0 to 3.0. Random urine will have 50 to 1,200 milliosmoles per kilogram. And then the osmolar gap, if ma-compute na to, would be 5 to 10 milliosmoles per kilogram. Okay, so that is it for the introduction sa inyong water and electrolytes. Okay, all of those you have to understand in prerequisite sa atuang electrolytes. As you have mentioned earlier, daghang functions ang atuang electrolyte. So if there is any imbalance in the electrolytes and the fluids as well, then a lot of those functions will not function properly. And kita physically ma-feel na nato sa atuang lawas. The first electrolyte that we will talk about is your sodium. It is your major extracellular cation. Okay, it is the most abundant cation in the extracellular fluid. Okay, and then it is 90% of all extracellular cations, as you remember. Okay, so your sodium largely determines the osmolality of the plasma. Your ATPase or ATPase ion pumps is an active transport system in all cells that prevent equilibrium and ensure concentration gradient. Okay, so your potassium is a major intracellular cation and your sodium is the major extracellular cation. So your potassium would eventually diffuse across the cell membrane until equilibrium is reached. Okay, so sa ato ang ATPase ion pumps, it moves three molecules of sodium or three sodium ions outside of the cell, and in turn, it moves two potassium ions in exchange into the cell as ATP is converted into ADP. So from triphosphate, name mo siyang diphosphate, so it uses energy to perform the exchange of ions. That's why it's an active transport. So when the sodium moves outside of the cell, so the water will also follow. So this will prevent the osmotic rupture of the cell by drawing water from the cell. Okay, so pag kana kung asa ang mas taas na concentration of solutes, dira pod naga sunod-sunod ato ang water. 'Di ba? Sa chem nato, ang water will always follow where there is a higher concentration. Okay, from lower concentration always to higher concentration. We have three important processes sa ato ang sodium. We have the intake of water in response to thirst. We have the excretion of water, largely affected by the vasopressin release. Excuse me. And then we have blood volume status, which affects sodium excretion through aldosterone, angiotensin 2, and your kanang natriuretic peptide, your atrial natriuretic peptide, which 'di ba, as you remember, ano niya ang sodium release or the excretion of your sodium. Okay, so you have to remember na kasagaran sa ato ang mga electrolytes by partner na siya. If na ay ginapasulod na electrolyte, tapos ginapagawas na electrolyte. So it has to have a certain electron neutrality. Okay, so that's why it always has to have its own balance. Okay, 60 to 75 of your filtered sodium is reabsorbed in the proximal tubule. And then, further na mga percentage will be in the loop of Henle, and then also distal tubule. And then those na mabilin na very small percent of your sodium will be excreted through the urine. And it is exchanged by your potassium in the connecting segment and cortical connecting tubule. So pag kita naga-reabsorb og sodium, naga-excrete pud ta og potassium. Okay? So kapag save or naga-conserve tag potassium, gina-reabsorb na to ang potassium, naga-release pud ta og sodium. So exchange lang jud na sila always. For the clinical application, hyponatremia is defined as a low serum plasma sodium levels, usually less than 135 millimoles per liter. It is clinically significant if the levels fall below 120 millimoles per liter. It's one of the most common electrolyte disorders in hospitalized and non-hospitalized patients. Okay, so your hyponatremia or your low sodium sa blood may be caused by increased na sodium loss, increased water retention, so there's dilution, or water imbalance, too much water or too little, or any such case. Okay? Pag naatay increased sodium loss, the first cause, okay? In these na mga conditions, the urinary sodium levels are usually less than 20 millimoles per day. Okay, so naga-decrease ang aldosterone nato, meaning wala tay sodium reabsorption. Kapag naay diuretics, sige pangihi, so naga-appeal ato ang sodium. Pag naay ketonuria, ano ta, daghan ang ketones sa urine, and then ginadala po niya ang sodium. If we also have salt-losing nephropathy, if we have potassium deficiency, so why increase ang or naga-lose ta og sodium ions when we have your potassium deficiency? Because our body will uh, try to cope by reabsorbing potassium. And 'di ba, whenever we reabsorb potassium, we will excrete your sodium. So, whenever we have potassium deficiency, our body will reabsorb more potassium and it will release more sodium sa atoang renal system to be excreted through the urine. Okay. So, also prolonged vomiting, diarrhea, and severe burns can cause increased sodium loss. Okay. So, under na po sa increased water retention, so this will cause dilution of the serum or plasma sodium as with acute or chronic renal failure. Okay. As in the cases of your nephrotic syndrome and hepatic cirrhosis, plasma proteins are decreased and there is also decreased colloid osmotic pressure, and the intravascular fluid migrates to the tissue and will cause edema. Okay, so pag nakita niyo na sa mga people ongoing dialysis, naga-edematous sila, nagababa ang plasma proteins nila, okay? And then ang intravascular fluid, which is supposed to be inside the blood vessels, will migrate to the tissue. And so, nagataas ang fluid retention sa ato ang tissue, causing edema. Okay? So, naanay role ang plasma proteins na to in making sure na everything is as it should be inside the vessels. So, pag nagababa siya, eventually, the intravascular fluid will migrate to the tissue, causing edema. Sa congestive heart failure, pagbaba ang plasma volume, nagaka-cause siya og AVP production to retain water. Okay, naga-retain ang fluid, and this will eventually dilute sodium. And if taas kaayo ang retention nato sa fluid, it can cause congestion or congestive heart failure. Increased water retention. Okay, still under increased water retention, we have your urine sodium. It is being used to differentiate the cause of water retention. Pag more than or equal to 20 millimoles per day ang urine, so ang problem is probably acute or chronic renal failure. Okay? Pag ang urine na pod is less than 20 millimoles per day, It is probably nephrotic syndrome or hepatic cirrhosis or congestive heart failure wherein gaka-dilute ang atoang sodium. Okay? Water imbalance can occur as a result of excess water intake. Kapag sobra-sobra na po ang water intake na to is in the case of polydipsia. Okay, we have your SIDH, okay, like we mentioned earlier. Then we have the defect in AVP regulation in the cases of pulmonary disease, okay, malignancies if na ay mga tumor, dili ta makaproduce or too much ang ginaproduce nato na AVP. If we have CNS disorders na dili siya makaproduce og AVP or dili siya makarecognize og stimulus in order to produce or stop producing AVP. If we have infections such as your katong pneumocystis cerevisiae, and then if we have trauma such as katong burns, 'di ba, or extreme blood loss. We also have your pseudo hyponatremia. So this occurs when sodium is being measured using indirect ion selective electrode in a patient who is hyperproteinemic and hyperlipidemic because indirect ISE dilutes the sample prior to analysis. The serum or plasma water this would cause serum or plasma water displacement, and then the ion levels are falsely decreased. Okay, this may also be seen in vitro hemolysis, which is the most common cause for a false decrease. Okay, when RBCs lies, ang sodium, potassium, and water will be released, and since ang sodium is lower sa RBC, so this would cause a false decrease as well. We have three categories of hyponatremia by osmolality. Okay, low osmolality may be a result of sodium loss or water retention. Your normal osmolality or normal concentration pero baba ang sodium may be a result of high increase in non-sodium cations. Your high osmolality, meaning concentrated ang yet ato ang body fluids, and pero baba ang ato ang sodium, may be associated with hyperglycemia. So dili ang sodium ang naga-cause sa osmolality but ang glucose. Pero baba gihapon ato ang sodium. We also have the symptoms of hyponatremia, which is dependent on the serum level sa sodium. Okay? If it is between 125 and 130 millimoles per liter, okay, the symptoms are primarily gastrointestinal. If it falls below 125 millimoles per liter, nagakos siya og nausea, vomiting, muscular weakness and headache, lethargy, and ataxia. Pag below 120 millimoles per liter for 48 hours or less, it will cause seizures, coma, respiratory depression, and it is considered as a medical emergency. Okay, so since nagababa ang ato ang, for example, nag-nausea, vomiting na ta, and then nagbaba ang ato ang sodium, kas nagasunod siya sa ato ang fluids. And then, our body will try to conserve the sodium, okay, releasing potassium in the process. And then, we will feel muscle weakness, di ba? Because naaman sa nagadepend man ato ang muscle sa potassium, so naga-feel tag headache, lethargy, ataxia, and then pag mababa pa siya samot, then we will experience the seizures, the coma, respiratory depression. So panic value na ni siya. Treatment for hyponatremia, okay, it is directed at the condition that directed at correction of the condition that caused either water loss or sodium loss in excess of water loss. Okay? The consideration sa treatment would be the severity of the hyponatremia and the onset. Okay, conventional treatment would be fluid restriction. Since baba na daan ang sodium nato, if we drink more water, it will further dilute whatever sodium we have left. Okay? And if mag-provide man jud ta og fluid, it should be hypertonic saline and or other pharmacologic agents. So, 'di ba? Pag mahubog ta, magsige tag suka-suka, matutag ospital. So, wala ta ginapa, drink og kanang water, 'di ba gina NPO, gina non-per-orem ta, and then gina fast drip ta og kanang saline solution so that ang katong electrolytes that we lost would be replaced. Okay? And then we will not um drink any water at first so that dili ma-further dilute ang katong sodium that we have left sa ato ang lawas. So the speed of correction, if it's too rapid, it can cause cerebral myelinolysis. If too slow pod, it can cause cerebral edema, nagalose tag proteins, okay? And then eventually, uh, the the intravascular fluid will go towards the tissues and then it will cause edema. Okay, so for those na ay IV line pag ma-ospital, dili nato dula-dulaan ang atoang katong naga-regulate sa speed sa atoang IV line because it will have detrimental effects. The speed of the drops sa atoang IV line is being calculated properly by the nurse and or the doctor in order to make sure that it is not being administered too fast or too slow. Okay? Because, syempre, direct siya sa atoang ugat and it will have detrimental effects if it is not administered at the correct speed. Okay. Treatment of hyponatremia, we have your Vaptans or your AVP receptor antagonists. Okay. These are found to be effective treatment for euvolemic or hypervolemic hyponatremia. Okay. Conivaptan blocks the action of your AVP in the collecting ducts of the nephron. So pag wala AVP, naga-decrease ang water reabsorption and this can be used for your euvolemic and hypervolemic hyponatremia. And this is not effective treatment for your hypovolemic hyponatremia. Okay? So, ang action sa conivaptan is ginablock niya ang katong AVP. So, dili siya maka-absorb og water. It is not effective sa hypovolemic because dapat sa hypovolemic, um, dapat mag-absorb tag more water since baba na gani kaayo ang volume. So, dapat naga-conserve ta or naga-reabsorb ta og water. If we use conivaptan, mo further exacerbate ang ato ang hypovolemia. Okay, so mulala siya. So, it can only be used for your euvolemic, hypervolemic, or hypervolemic hyponatremia. Okay. So, your euvolemic or euvolemic hyponatremia is associated with SIADH, adrenal insufficiency, and rarely hypothyroidism. Your hypervolemic hyponatremia, taas na volume pero baba ang sodium, is associated with your liver cirrhosis with ascites, okay? Your congestive heart failure, and your overhydrated post-operative patient. So, overhydrated siya, taas ang volume sa fluid, pero diluted man po ang fluid or diluted man po ang sodium. So, taas lang siyang volume pero baba siyang sodium. Okay, dire normal lang iyahang volume pero baba gihapon siyang sodium. Hypernatremia, there is an increased serum sodium concentration and this results from excess loss of water relative to sodium loss, decreased water intake, or increased sodium intake or retention. Okay? So, promise hangtod sodium lang ni siya na recording. I know medyo too much information na siya. Okay, loss of hypotonic fluid. So, there is an increase in serum concentration and this results from excess loss of water relative to sodium loss, decreased water intake or increased sodium intake or retention. So, the loss of your hypotonic fluid may occur either by profuse sweating, diarrhea, severe burns, or um, kidney. Okay. So, naga-lose tag fluid and pero naga-increase ang ato ang sodium concentration. In the case of your diabetes insipidus, if it's nephrogenic, the kidneys cannot respond to your vasopressin. If it's central, your vasopressin secretion is impaired. Okay, naga-produce tag dilute urine because all the water that we drink will not be reabsorbed or cannot be reabsorbed. And so tanang ginainom nato gina-release nato. And hypernatremia does not occur unless thirst mechanism is also impaired. Okay? So loss of hypotonic fluid in the case of renal tubular disease, if you have acute if in the case of acute tubular necrosis, tubules become unable to fully concentrate the urine. Okay, so through we can also lose hypotonic fluid through the skin and by breathing. This is what we call your insensible loss. Okay, so every day we lose about 1 liter of water just through our skin and just through breathing. So imagine if wala ka naga-drink at all og water in a day and you're already losing 1 liter just by normally functioning, just by breathing. Okay? So, taas po dato ang osmolality sa body. That's why feel tag sense of kanang kauhaw because we are losing 1 liter of water just by breathing. Okay, that's why we cannot survive long if wala tay water. Mas makasurvive pa ta longer without food but not without water. Okay, decrease water intake. So this will be those who may be thirsty and are unable to ask for or obtain water, such as adults with altered mental status and also infants. We have excess ingestion of salt or administration of your hypertonic solution. Okay? In the case of sodium bicarbonate, so syempre na is salt, sodium. 'Di ba we use sodium bicarb for heartburn or indigestion and or correction of acidosis such as your Gaviscon, okay, Algina. I don't know if Kremil S will be considered if sodium bicarb ba siya. Okay? So if we have excess ingestion of those na mga um tawag ani medicine, okay, it can cause hypernatremia. Okay, hypertonic dialysis solution, okay. So if hypertonic ang gihatag sa ato na IV line or hypertonic and dialysis solution na to, then it can cause hypernatremia as well. Okay, chronic hypernatremia is indicative of hypothalamic disease if patient is alert, usually due to defect in the osmoreceptors. If it's defective, either dili na niya ma-signal na too much na ang sodium reabsorption or dili na need ang aldosterone or dili na siya makaingon na kanang dapat i-release na ni ana. So wag na problem sa receptors or na problem sa hypothalamus. You also have your primary hyperaldosteronism. So there's excess aldosterone which induces mild hypervolemia. Since uh, release tag aldosterone, so reabsorb ta og sodium and then um, reabsorb pud ta og water in the process. Nagasunod siya sa sodium. So, if reabsorb tag water, then our body will say na kanang, okay, okay ang osmolality nato. Dili need mag-release og AVP to reabsorb the water since nagsunod siya sa ato ang sodium. And this will eventually increase plasma sodium upward by 3 to 5 millimole per liter. So, what are the symptoms pag taas og sodium sa body? We have altered mental status, lethargy, irritability, restlessness, seizures, muscle twitching, hyperreflexes, fever, fever, nausea or vomiting, difficult respirations, and increased thirst. Okay? So, pag more than 160 millimoles per liter na ang atoang sodium, it already is associated with a mortality rate of 60% to 70%. So, what is the treatment for our sodium? Okay, it is directed at correction of the underlying condition that caused water depletion or sodium retention. The speed of correction depends on the rate with which the condition is developed. If naatay serious na hypernatremia, which is what we mentioned earlier, more than or equal to 160 millimoles per liter, if too rapid ang correction na to, it can induce edema or death. So the maximal rate of correction sa hypernatremia should just be 1 millimole per hour. Okay, when testing for sodium, the specimen that we can use would either be serum, plasma, 24-hour urine, or sweat. If we will use plasma, the preferred anticoagulants should be lithium heparin, ammonium heparin, or lithium oxalate. Sources of errors would so hemolysis is not exactly a significant na source of error because 'di ba extracellular man ang atuang sodium. But if there is marked hemolysis, it may decrease the levels of your sodium because baba man ang sodium sa blood and madilute pod ang kanang value of sodium na naa sa sample nato. Okay? What we use sa ato ang lab is our ion selective electrode, which is the most routinely used in the clinical laboratory. So it uses a semi-permeable membrane, okay, to develop an electrical potential produced by having different ion concentrations, okay, on either side of the membrane. So lahi-lahi siya na concentration on either side of the membrane. So you use these electrodes, okay? And then one electrode would be constant with it will have a constant potential, which we will call the reference electrode, and the other will not have a constant potential, and that is the measuring electrode. The difference in potential between the two electrodes can be used to calculate the concentration of the ion in solution. However, it is the activity of the ion and not the concentration that is being measured. So when we use ion selective electrode, dili ang concentration ang gina-check na to, but the activity of the ion. Most analyzers use a glass ion exchange membrane in its ISE system for specifically for the sodium measurement. So we have two types of ion selective electrodes. We have the direct type and the indirect type. So for the direct type, it provides an undiluted sample, which is whole blood, to interact with the ISE membrane. If it's indirect, it uses diluted samples such as your plasma or serum for measurement, and it is used for most automated chemistry analyzers. So, makakita na mo ana pag pohon, pag naana mo sa ospital, you will see kung asa ginat test ang blood gas, diretso ra na siya with the whole blood na naa sa ato ang syringe. Gina-insert na siya dito sa may probe and ang whole blood mismo ang gina-test niya. Pag indirect, we use either the plasma or the serum. So that is for your chemistry analyzers. Okay. The source of error for your ion selective electrode is the protein buildup in the membrane through continuous use. So the solution for this one is for routine maintenance of your ion selective electrode to which requires removal of the protein buildup to ensure quality results. So usually gina-change jud nato na ang katong electrode na naa sa machine. Okay. So that would be all for today. And I hope na advance reading mo on the other na mga um, elect uh, electrolytes. And also do remember to study or review the coping mechanisms of the body, especially in terms of katong sa unsa ang effect sa aldosterone, unsa ang effect sa arginine vasopressin, para sa asa or how does the renin-angiotensin aldosterone system work. Okay? So, those are the processes that you need to focus on. Okay? And then do try to remember ang katupon mga reference range sa ato ang mga electrolytes. Okay? Especially ang units pod nila. Thank you for listening, and I will see you next time. And we will have a quiz before we start our next na lesson on electrolytes, which should be your potassium.